Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
I'm James Larkin. Hi.
Okay, so today we wanted to do the IGNYTE study, RP1 plus nivo. And this was published in JCO. First author, Mike Wong. Shout out to Mike Wong. And before we do that, we need a quick fire. Maybe you can tell us what all that noise is outside your door. That's not really a quick fire. But...
No, it's not outside the door. It's outside the window.
Oh, is it?
Yeah. There's the road's right down there, and then it's where the ambulances come and go as well. And it's narrow streets in Chelsea. So most days there's some sort of low to medium level conflict between drivers on the street and shouting. So it's deadly.
We can usually hear the car sounds from this side of the pod world.
Well, did you hear that? I don't.
Good timing.
Yeah, I don't know what to do. So I could close the window.
It's fine. It's week 2 of the new year, right? And actually, I usually fuss at you for time stamping these because then we don't publish them for a while. But we're going to try to do better about it. And week 2 in the gym for you, where do you stand on the leaderboard at the gym?
Oh, what you mean today? Do you want real?
Is it a daily? Is it a sure?
Yes, it's a daily update. Yeah. Every day you go, you look at scores, and then you have a bit of banter with your friends. Which
so
of
there's
course,
not a weekly.
No. It's daily. So I don't know if I should mention any of my friends by name, actually. Do you think that's right or not? No, I probably shouldn't, should I? But me and a particular friend have a little bit of fun with weightlifting, whereby if one of us has gone first, the other one will then try and do 1 kilogram more on the lifts using these tiny... Yes, exactly, tiny little white plates. And lo and behold, Dom, my friend, I'll say Dom, has just beaten me by 1 kilogram, and his comment is just for larking, for the benefit of everybody in the gym. Thank you, Dom. Big shout out. Lovely guy, Dom. I won't say a surname. I'll get Dom to watch it though, if it's his back.
So you're the number 2?
No. This, I think Dom was 3 and I was 4, something like that. So far. Bearing in mind that the evening hasn't happened yet, this is just based on the morning, so I'll probably slip.
Oh, there's evening classes?
Yeah, morning and evening. Yeah, that's the, kind of 6 till 10, 11, then break, and then, a lot of people go in the evening.
Wow.
Yeah, they tend to be younger as well, the people in the evening. So they're probably fitter and stronger, or they should be.
Do you think there's some psychology between who works out first thing in the morning and who works out in the evening?
I think it's all job related and sort of domestic commitments. I think the bottom line is anyone who's got young children has to go in the morning because the evenings are just carnage, basically. I think that would be the quickest summary. Carnage. Actual carnage.
Cool. Okay. You ready to get onto this article that you've read cover to cover?
In detail. Yeah, so Mike Wong, lead author, JCO. Let me just get this out. I think it was July last year or thereabouts, 25 actually came out. I'm just trying to look at the stamp on that. Anyway, that's roughly correct. There's a lot of other authors. Caroline Robert's the senior author, and actually Kevin Harrington and Lizzie Appleton are on this as well from my institution. Actually, Lizzie, I can't remember if you met her or not. Very talented clinician scientist in training, and a load of other colleagues. So RP1 combined with nivolumab, an advanced anti-PD-1 failed melanoma is what they called it. 140 patients, non-randomized, needed to have confirmed progression on anti-PD-1 therapy. The RP1, I don't know if we're going to talk about it too much, exactly what it is, but maybe a simple way to think about it is it's an improved version of TVEC. I guess we could go into the detail on that. Kevin, actually, I hope you won't mind me saying this in public, Harrington calls it TVEC on steroids. But have I said that to you before? And I said, well, when Kevin said that, I said to him, Kevin, you mean metaphorical rather than literal steroids, because presumably you wouldn't want it to be actual.
What a dorky comment.
What a dorky comment.
Oh
that is
God.
that is exactly right. Where did I get to? Anyway, delivered intratumorally, and then primary endpoint objective response rate. I'm going to stop there and let you have a turn if you like.
Nope, continue.
All right. So I might just cut straight to the data actually, and then we could chat a bit about that. Table 1, baseline characteristics. I thought looked reasonable. BRAF mutation rate 40-odd%. That looks about right. I mean, I probably would mention the 3B, 3C, 4M1A, 51%, 4M1B-C-D, 48%. So I always wonder when those kinds of things are showed, because 3B and 3C are not the same as stage 4 disease. Oh, anyway, so that would be just one thing I'd maybe mention. Normal LDH 2/3, just under 66%. High LDH 33%, LDH greater than twice the upper limit of normal 6%. Prior therapy, so you could have had anti-PD-1 only as adjuvant, 25%. Other than adjuvant, the rest, 75%. Anti-CTLA-4, 43%. Combined with anti-PD-1, sequential 3%. Maybe one little thing actually, Sapna. Received BRAF MEK therapy, only 12%. So thinking about the trial population, 40% BRAF mutant, but only just under a third of them had actually had BRAF targeted therapy. And then they've got primary and secondary resistance, and that's 65 versus 34% respectively. And the definition, I should say, while I'm on the subject, primary resistance defined as progression within 6 months of starting the immediate prior course of anti-PD-1. Secondary resistance, progression after 6 months of starting the immediate prior course. So I don't know. I mean, they don't list tumor volume, for example, and I guess we'll come on to this. In the lifileucel registrational cohort, which has been shown a lot, obviously, over the years and published a lot, one of the things that people pull out of that is the sort of tumor volume, I guess. But at least I can't see that listed here. You look like you want to say something.
Yeah, I don't recall the lifileucel tumor volume, unless you're talking about tumor harvest, size of tumor harvest, but I don't recall
mean sum of diameters around 10 to 11 centimeters. So I think most people would say that's significant. Carry on.
So there's a few things with this table 1. You were talking about the different stages, 3B not being the same as 4. That is right. But 4M1A, for the purposes of these intratumoral, 3B, 3C being lymph node, and by the way, 3B, right? How about that? Lumping that into this advanced PD-1 refractory trial. I think that's a coding error, because what patient with 3B is still 3B PD-1 resistant? Do you know what I mean? Like palpable lymph nodes only with an intact primary or not, resected primary, but just palpable lymph nodes. I think that is a coding error where the patient started out 3B and then whatever they got, so like that's one of the caveats with these clinical trial databases. They really need to take ownership. And are we coding this right? How could you have a 3B in a second line or beyond trial, first of all? But 3C, yes, of course, that's some in-transit stuff. That's also lymph nodes with in-transit. 4M1A is that regional lymph node soft tissue metastasis where an intratumoral could be injected. And I think separating that from visceral stage 4 is fine. So I'm okay that they did that. To compare this to TVEC, though, TVEC really doesn't have a lot of efficacy in the visceral organ space. And so it is nice to see this trial was approximately 50-50, in the sort of lymph node soft tissue versus visceral organ. And that's one point on the baseline. The other point, of course, this LDH, only about a third of patients with a high LDH. Is that the normal situation in the second line and beyond advanced? Maybe. I don't know. I don't have too much to say about that, but what do you think?
I think ballpark, yes. Okay. I wouldn't have expected it to be lower, certainly. But I mean, it shows you
higher.
Yeah, exactly. So I think it shows you there clearly are some trial participants in there with bad disease.
And then two other bits, only half of the population, 43%, so less than half, had gotten concomitant CTLA-4 PD-1. And that is not your current state. You would probably think it's more than half. Now, Opdualag use is increasing, and so, but it doesn't quite come out here, what portion of this trial might have been Opdualag exposed. And maybe the dates of the study are such that we didn't have it. But just making the point that 50%, less than 50% having received PD-1 plus CTLA-4 in combination doesn't feel like today's population. And then the last thing is, as you said, that definition of primary and secondary resistance is their own definition. This is not in line with the SITC definition, which we discussed in episode, quick, SITC resistance.
No.
So in a previous episode where we discussed primary and secondary resistance for the SITC white paper, and there it was, minimum exposure of, I think, 6 weeks or so with no objective response. Here, it's just, in this definition, it's how much exposure did you have on your previous previous anti-PD-1 therapy. So it doesn't speak to whether it's really primary resistant, you got no response from it, or you had a response and then you lost it, secondary resistance per SITC. It's just more of a, how long were you exposed to your PD-1 based therapy? So that matters. And, what we're not saying here, but maybe we're saying this was the data set that went to the FDA for a sort of accelerated approval, if you will, non-randomized. They were following very much kind of what lifileucel did, giving about 150 patients, 140 here, in a non-randomized fashion in the PD-1 experienced or PD-1 progression setting, and showing what you're going to tell us is the response rate, and saying to the FDA, does this look good to you? Because it certainly looked good for you with lifileucel. And by the way, we will confirm this in a randomized phase 3. And unfortunately, as of summer of 2025, the FDA took a look at it and said, no, this data is not enough for accelerated approval. They've since decided to revisit the issue. And the company has a PDUFA date of April 2025. And it's possible this data gets reviewed before then. So ultimately, their randomized phase 3 is underway, which is good for patients and good for investigators. Okay, over to you. Objective response.
Intra-podcast fact check. I think you just said April 2025. Did you mean April 2026? All right.
Ooh.
See, that proves I listen at least sometimes. All right. So cut to the chase. Confirmed response rate 32.9%. Confidence intervals 25 to 41%, 95% obviously, confidence intervals 15% complete response. And then there's this, and I'm actually reading this from the abstract, responses occurred with similar frequency, depth, duration, and kinetics for injected and non-injected, including visceral lesions. Maybe come back to that in a minute. Before that, though, I was just going to say, to your point about registration, they actually described this as the registration intended cohort in the manuscript. And then I think I don't know, maybe I'm wrong about this, but it feels like the table that gets sort of shown most in other sorts of presentations is table 2 actually here, where they try and break down response across all of these different groups, and it's quite a busy table, actually. I mean, I might just pull out a couple of things first of all and then go back to you before we talk about some of the other stuff. So yeah, you sort of, I look at it and I think, what should I be looking at, honestly? But maybe working from the right, PDL1 expression much higher, 52% in positive than negative, 24%. BRAF, no real difference, mutant versus wild type. Adjuvant anti-PD-1. So if you had adjuvant, response rate 44%. If you hadn't, 29%. So all small numbers, massive caveats here, obviously. Anti-PD-1 resistance per their definition looks about the same, 29 versus 34%. The 3B, 3C group, including stage 4 M1A, 40% for 0 versus 25% for 4 M1 BCD. So that kind of looks different. And then the final one is prior anti-PD-1 with anti-CTLA-40 or 0.26%, without 38%. So, I mean, what do you say about that? All these small groups and wide confidence intervals. I mean, it's kind of interesting, isn't it? But I think pretty descriptive, actually. And, you know, we're all going to have our biases about this, I suppose. Over to you. You were just about to say something.
I wonder if I could clarify something you said with the PD-1 exposure in the adjuvant setting versus not exposure in the adjuvant setting. The response rate's higher in that group of patients who, so I just, a bit of clarification, because as I heard it in my ears, I thought, why would a group that received anti-PD-1 in the adjuvant setting have a higher response rate than a group that didn't receive it in the adjuvant setting? It's more, and they say it in the text, was your progression on anti-PD-1 in the adjuvant setting, or was it progression in the non-adjuvant setting, i.e. metastatic setting?
Yeah.
So this progression on adjuvant is they were on their adjuvant therapy, progressed, and this was what they got next. They got RP1 plus nivo, as opposed to the other group who got something in the frontline metastatic and, or, you know, whatever line metastatic, and on that progression of anti-PD-1 grabbed this. So it's essentially the idea of going from a scan that was negative to a scan that's positive and jumping in with this treatment. So probably smaller volume of disease than already metastatic disease progressing. And what does that tell me? It tells me a couple of things, and I hope pharma companies, you know, take this to heart. I wasn't going to say are listening, because we know there's nobody listening. But these are not the same group of patients, as you just enumerated, by an objective response rate difference of, what, 16% or so? Small numbers, I get it. I mean, sort of small numbers, right? It's 36 patients and 104. But I will say progression on adjuvant anti-PD-1 is not the same as a frontline metastatic patient.
No, absolutely not. I mean, we could get into a whole thing here, I suppose, and we talked about this a bit before. Some of it comes back to definitions of resistance as well. But if you've got someone who's really had an adequate trial of adjuvant anti-PD-1 and they're progressing through that, I mean, that for me is a strong definition of resistance to anti-PD-1 therapy. And then, you know, we have talked about this before. This is part of the issue, I think, with these populations. They're quite mixed, and in many ways, I think, difficult to really draw confident conclusions from. So
can I make a couple of comments as we're talking about response? One of the key things here is that these are responses in visceral organ sites. So as opposed to TVAC, where we were mostly injecting superficial and looking for this bystander effect, these are injections into visceral organs and bystander responses in visceral organs. So you're getting sort of both of those things that we were seeking in that first generation of intratumoral. So you would see distant responses in the brain. You could see distant responses in the spleen. I can't remember if they had bones as a site of distant response, but that's fantastic, because historically those are, you know, visceral places we wouldn't want to inject, but you can get the response there. So I think unequivocally, and you can sort of, they're trying to show this in figure 2A, the reds and the blues. There's absolutely no way even anybody in print with their journal in front of them is going to get this from figure A, because it's way too paneled and small. but each patient is like a small column at the bottom, and they're injected and uninjected or coded together in one column as blue injected, red uninjected. And what it's meant to show you is that as goes the injected lesion, so goes their uninjected lesion. So almost uniformly, the injected lesion responds, the uninjected responds. So that's nice to see. You also got complete responses in uninjected lesions. That's nice to see in that plot. I think you can't make heads or tails of this spider plots. I think I told the sponsor this. These spider plots have like 60, 70, 100 patients on these spider plots. How can you tease out an individual line? I don't know why they think that's helpful. You're just getting a general shape, but I can't tell you where any one patient's kinetics are when it's all jumbled like that. So I think you have to be really careful when showing spider plots that you don't have so many patients on there that you can't actually follow individual patients. But it is nice to see that you can get uninjected tumors completely going away. And then panel D, total tumor burden. There you go. There's your total tumor burden.
Where am I looking? Oh, yeah.
Figure 2D.
Yeah.
I'm not sure I've seen that plot before, and I don't really get it just looking at it quickly, but yeah, that's fine.
Yeah, again, it's the same comment though, isn't it? I mean, I'm having to make it quite a lot bigger, and it's probably my age and eyesight. Even then, yeah, it's not kind of intuitively sort of easy to grasp, is it? I think that's fair. I was going to just maybe go back and quickly talk about figure 1 in the interest of completeness, if that's okay. You look nervous.
No.
So, duration of response, median duration of response. This is figure 1A. So 33 months. I think that's pretty important, actually. If you think about other treatments we've got and duration of response and so on. So I think that, that really speaks for itself. I think I can never get excited about figures, the B and C though, which is probability of PFS or OS, depending on whether you responded or not. Guess what? If you respond, you're going to have better PFS and OS than if you don't. That doesn't sort of tell me too much, honestly. And then
and time zero doesn't make any sense there anyway. I mean, these kinds of graphs are so statistically invalid.
More problems with time zero. And then 1D is a swim plot, and then 1E is a waterfall plot. I think they sort of speak for themselves. But yeah, so I didn't really have too much more to say than that about figure 1.
I'm looking at something here. Hang on. Yeah, 1B and 1C are invalid graphs. You can't graph all patients and then also add the responders and non-responders in there, because the time zero is different for them. You're only a responder at the time of the first scan. So B and C, JCO, how dare you publish that without a good statistical review? My colleagues in SWOG have taught me. Maybe we should talk about toxicity if you want to jump to table 3, and then we'll make a final comment that doesn't really jump out here, but I can just sort of tell you, and it's about how to choose whether you're injecting a superficial lesion or a deep, all superficial, all deep. I can just chat with you a little bit about that.
Yeah, maybe before we do that, just to mention figure 3, which is the RNA-seq analysis. Again, that's a lot of information there, which I'm not, it's good to have done it. Kudos.
Praveen Bomaretti, who's the guy at Replimune who probably did all this.
Yeah. But just to pick out the comment, which in fact is in the abstract as well, demonstrates broad immune activation associated with response, increased CD8 T cells, and PD-L1 expression. But good for them.
Just with a caveat, James, sorry to interrupt, just with the caveat that RNA-seq data is on 19 patients. So
yeah, indeed. So then tox, table 3.
Yep, go.
Question mark. So TRAEs grade 3 or worse, 12.9% is the sort of the first thing that took my eye. Then I look down the grade 3 column and I just see really it's sort of a smattering of one event: fatigue, arthralgia, decreased appetite. So really not much that's grade 3 or worse according to this. And then if you look at the any grade, which is the other column that they're showing, and then this is highest to lowest. So fatigue, almost a third; chills, almost a third; pyrexia, almost a third. And then lower than that, you've got some nausea, flu-like illness, injection site pain, and maybe those.
So pop quiz.
Try me. Go on.
Which of these side effects are from the nivo and which are from the RP1?
Well, I am going to say that chills and pyrexia, influenza-like illness, injection site pain, and injection site reaction are the things that I think are most likely as a consequence of the RP1. And then the others would definitely do for nivo. And then, of course, you're going to have a sort of contribution of component situation for toxicity as well as efficacy, non-randomized study. But I mean, I think the bottom line seems to be that, again, from this, I mean, I never like it, as you know, when it just sort of says any grade. I am interested in grade 1 versus grade 2, actually, genuinely. Because are those side effects mainly grade 2 or grade 1? Actually, that makes a difference for patients. But it looks like it's pretty well tolerated to me. But go on.
Yeah, no, I mean, you've certainly probably had a checkpoint inhibitor patient who occasionally gets pyrexia or chills. And yeah, it's hard to know. It's hard to know whether it's the combination that leads you to this much of that, or if it's really just driven by the injection. It doesn't really matter. It just was just a teasing question. Is whenever we have combinations like this, how important is it to assign it to one or the other? You know, the TIL trials are famous for this. Is this the lymphodepleting chemo? Is it the TIL? Is it the IL-2? My gosh, it's tough. And then just a comment, you know, the data may not totally be in here, but I've seen it where if you have a patient with superficial and visceral disease, by the way, that's the most common flavor of a PD-1 progressing metastatic patient is going to be, you know, visceral disease or visceral with some superficial soft tissue or lymph node. That's my opinion. May not be factual, but it's my opinion. And in that situation, do you inject just the soft tissue stuff? Do you inject just the visceral stuff? Should you inject both? And they have, again, very small numbers because you start parsing this 140 patient data set up. But when you look at just the ones with superficial soft tissue, the 3C, the 4M1A, and just injecting those, you get a certain response rate. When you just inject deep, you get a certain response rate. It turns out when you have both superficial and deep and you inject, you go after a little bit of both, you get the highest objective response rate. It's in the high 40s. So, you know, one of the thinkings here might be that if you have, you know, a variety of places to inject, then mix it up a little bit.
Yeah. So the bottom line there is, if you're not sure, go superficial and deep. Is that fair? Just to, and this is in the text actually, in the safety paragraph next to table 3, I think this is worth saying that there were 5 grade 4 treatment-related adverse events. So 1 cytokine release, 1 hepatic cytolysis, I'm not quite sure what that means, 1 lipase increase, 1 myocarditis, 1 splenic rupture, no treatment-related death. So actually 5 life-threatening, by definition, if they were grade 4 adverse events in 140 well-selected clinical trial patients. I think that's going to be worth watching in the future, actually.
Yeah.
So if I may, the only other thing I was really going to kind of bring up before we sort of talk a bit more and wrap up was this, sorry to go on about it, but, you know, I'm obsessed at contribution of components in this situation. And they say in the discussion, I'll just read it, previous studies have shown that only 6 to 7% of patients are expected to respond to continued anti-PD-1 monotherapy after confirmed progression on an anti-PD-1 containing regimen. I think that's quite a strong statement, actually.
Do they have a citation for that, for 6 to 7%, or no? They're just
the
making it as a
citation's
statement.
33, which is actually, that looks like it's a review by Tony Rebus, John Kirkwood, and Keith Flaherty in Lancet Oncology 2018. Let me just double check that.
So that's before S1616. That's before the Dan Olson, the Ines Perez de Silva.
Yeah, and I think, so that's right. And I just think that's a very strong statement to make, and that's a very precise number. And it's, in my opinion, almost certainly not right. I suspect it's a little bit higher, and it's particularly in these heterogeneous populations. Nevertheless, for the record, the efficacy seen here, I think, is certainly more than you would expect, quote unquote, expect to see with anti-PD-1 monotherapy. So the signal looks real for me, and it looks like
even if half the study is 3B, 3C, 4M1A.
Yeah, I think there's a signal. I'll commit myself. I think there's a signal here for RP1.
So I'll grab it from you and say, I agree. Congratulations to the sponsor and the authors, and congratulations on trying to take this to the FDA. I mean, there's nothing wrong with trying to take it. The data, we've seen it now. It's time, it goes. But maybe the bigger congratulations is that they've committed to do this phase 3 called IGNYTE-3. And it's basically PD-1 progressing patients get randomized to a limited choice of standard of care investigator options versus RP1 plus nivo. It's worth saying for that duration of response, 33 months, I believe you only get 8 RP1 injections. And so the rest of that time is just spent getting your nivo. So that's also pretty cool that, it's just turns into kind of maintenance checkpoint inhibitor. And this randomized phase 3 that's going, even in the absence of an accelerated approval, you got to show randomized data, and that's what it's going to do.
Yeah. But just to round that out, though, so 400 patient randomized study, I think, primary endpoint overall survival. So look for in due course. So we're done.
Yeah. Thanks for this.
Bye.